you can just mute your microphones at the moment. It does interfere with some of the playback for other participants online. As is our custom, I'd just like to take this opportunity to acknowledge all of the traditional owners of the lands on which we're meeting on around Australia and pay our respects to their elders past and present, and also to acknowledge their emerging leadership, particularly those who focus on sexual and reproductive health, which is the topic of today's webinar, focusing on knowledge exchange. So it's very difficult to understand what level to start to target some of these discussions for knowledge exchange, and specifically those for sexual and reproductive health. So I'm just going to spend some time then talking through a little bit about what we're going to do in this space. I'm going to focus a little bit about what knowledge exchange looks like for me in this field and what my experiences have been, considering how long I've been involved, and some of the early initiatives and incentivised strategies that we used. I'm also going to focus a little bit on some of the practical elements of knowledge exchange and what we can do, both in low-tech opportunities, utilising social media, and then talk a bit about how we do it. And finally, then I'm going to focus on some additional resources and some strategies that people can then incorporate into their own practice. And hopefully this will give you just a good overview about some of the issues and points of reflection that we've had in this field, and particularly around information flow, which for me has been incredibly important. So just to talk about my knowledge exchange experience, in the early 1990s, I was out in Central Australia, and I'd just become the coordinator for the Tri-State project, which operated across 4 different state jurisdictions with Commonwealth investment and interest, and it looked at working across 7 different language groups with 7 different health service types, all in the area of Central Australia, with a focus on sexually transmitted infections, HIV and AIDS at the time when the health promotion activities were really focusing on the Grim Reaper ads, for example. And so when we first went out to communities to talk about these sorts of issues, I was told very clearly 2 things that really resonated and stuck with me. The first was that we don't have anyone with HIV here, and if they ended up with AIDS, then we would take them outside and shoot them like dogs because we don't want to have to deal with these issues. And then the second thing was that even though there was an incredible burden of sexually transmitted infection, ill health, it really wasn't part of clinical practice. There was certainly no population level strategies around it, intervening well and with great effect. A lot of the health service systems were all paper-based, and so people were getting lost, particularly in the transitions from hospitals back out to home communities and vice versa. And medications and the diagnostic tools were not as they were today. So we hadn't done the DNA testing for asymptomatic illnesses, and it was still a highly invasive sort of strategy to understand whether someone had a STI, and then going through the treatment regime was really very difficult. And so amongst all of these sorts of really strong issues, we were also working with Ngunnapa Health at that time, that had started to implement the annual sexual health screens and having discussions at a governance level around doing this kind of work, and some individual effort that we were able to capitalise on. But I remember very clearly being told that you can't go out and talk to about sexual health with anyone in communities. You're not from here and you can't talk to men, which was supposed to shut me down. But instead what I ended up doing was smiling like an assassin, and then I went and got all of my canvases and paints and went out bush, as you do when you're a young stroppy woman. And I ended up being able to collect over 100 paintings in an 8-week period, which specifically talked to us about when people were at risk of contracting STIs or HIV. And one of the things that I ended up doing was working with a traditional owner who was working with me in the communicable disease unit, and I asked her to do a painting about STIs and HIV that we could then use as a descriptor of a narrative around how these things were being transmitted across different communities, and to also emphasise the burden of STIs and the potential then for the HIV to come in through STI transmissions, and also this idea of this threat being coming. So it's not that we wanted to articulate that people themselves were problematic, but that there were going to be situations and circumstances where they didn't have any control, or that their experiences of empowerment were such that they were going to be at risk, particularly of sexual violence at that particular time. What we ended up doing then was taking that painting plus a whole range of other really engaging, very colourful workshop processes, and we went out to communities. One of the things that we ended up doing was laying out big sheets of paper and canvases so that people then actually worked out a map. So where was the hospital, where was the clinic, where was the store, where were kids going to school, where were the roads, where were the houses, where were the sporting fields, where were people mostly driving, where were people getting traditional food sources and the like. And then we kind of got people to match up then what kinds of resources empowered them or helped facilitate their everyday life and what they could get from those different sets of community infrastructure. What we were doing in that instance was just kind of understanding then where people were accessing, what they were accessing, and how they utilised these different pieces of infrastructure in their everyday life, because what we wanted to do was provide messages for people in ways that actually helped fit and accommodate within their everyday lived experiences. From those then, what we ended up doing in the workshop process was to map out this painting and then generate some other ideas from within the community about when people thought that they were going to be at risk of contracting either an STI or HIV. And then what we were able to do then was use those paintings as ways of being able to communicate with great impact to a workforce to show that what we needed to do was put in place condom distribution strategies at this point, or before people ended up winning big money at card games, that was a time when you needed to be able to provide some health promotion information or equip them so that when they went into town, they could come back and they wouldn't have contracted an STI while they were in town. And so there were a whole range of different things that happened. We could talk about behaviour change. We could talk about personal safety strategy. We talked about the differences in behaviour during the daytime and then nighttime. And so there became different emphases about different behaviour change strategies and personal safety strategies that were different during the day and night. And then what we ended up doing with all of the resources generated from that process was we made some low-cost storybooks in language. We laminated them, we took photographs of the paintings, and we sent out a whole big package back to the communities around STIs and HIV to help inform them of what they wanted to have happen. But it was also then we were also, because of the ways that we had the discussions about how people wanted their family members to be treated if they had HIV, it was some of the preliminary work that we were able to do to help develop up clinical policies and community strategies around how to manage these instances if they are ever diagnosed. And it was really very clear from the paintings and drawings about these big networks that people belonged to, who had to the kind of information that you gave to people was not as important as the information routes through kinship relationships about how those messages needed to get to people. And as I said, we got over 100 paintings of when people were at risk of contracting STIs and HIV, and some of them were predominantly around having women removed from remote area communities to go back into hospitals to have babies. That was seen to be a critical time. Card games, and then people leaving communities to go into town to buy vehicles. Also, then we had discussions around domestic violence, and when people were making up or getting back together into couples, that was when STIs were being transmitted. There were also some really important ideas then around young girls and young boys and sporting carnivals in particular. And what we were able to do then was use these narratives, place-based narratives, to help really design some good health promotion activities and interventions. And so what I learned from that was, particularly in the space of talking through STIs and HIV, was never let someone else's no be your yes. You know, so if someone else has a threshold about their level of comfort in having these very important discussions, in terms of knowledge exchange opportunities, there was a great deal of information, facts and opportunities that we could have provided for community people. And we did do that. but some of the gatekeepers and some of the barriers were very much about shutting down, not allowing or facilitating those kind of conversations. And so we had to be very, very clear in our messaging. And so what we ended up doing was working with groups of people who are often disengaged or marginalised from the kinds of mainstream style services that other people were able to access. And in those early days, a lot of our community, men and women, were ostracised from their communities because they had either identified as gay, lesbian or transgendered, or because they had had HIV. And so at that point, there was lots of different communities that were excluding our people rather than being inclusive. And so one of the other things then that we did was work with people who had experienced that level of marginalisation and disenfranchisement and brought them back into being the primary informers of health promotion and other styles of activities. And so again, in those early days, we ended up developing up a management of HIV manual for primary health care that was absolutely based on the voices of HIV positive people and their carers. And that was a really critical breakthrough moment for us in this whole response that was about exchanging knowledge from those who needed to access services and those who in some ways refused to provide those services to them. And so what we ended up doing was finding a legitimate way of being able to communicate this need through the development of a clinical guideline that helped inform that level of practice. The other thing that we found incredibly powerful in terms of knowledge exchange was peer education. And for us, what we ended up having to do, particularly in light of some of the blood-borne viruses, was to go and talk to drug sellers, illegal drug sellers, about how to inject drugs safely. And then we encouraged and supported them to teach their clients on how to do that level of work. And so for us, working in this very volatile period of time, a lot of it felt really very subversive. Our knowledge exchange was very much about empowering people with correct information, and then we sugar-coated it and legitimised it through clinical programs or through health promotion strategies. And I know this Condom Man came out of the Townsville initiatives way back in the day. Graceland Smallwood was a really big supporter of Condom Man in his first iteration. But then as a result of using that, she had to take on the whole Phantom Conics and had to change significantly some of the elements of Condom Man so she wasn't breaching any copyright issues. And so instead of being an empowering process for everyone, it ended up being we ended up having to deal with some of the legal parameters around these sorts of initiatives. So what we've found is that knowledge exchange in this field is absolutely political. It has set precedents. It is about insightfulness, really focused on empowerment. It also had a lot to do with healing, not only about behaviour change, but around healing people who had felt ostracised and didn't feel like they belonged anywhere. A lot of the information was culturally sensitive, particularly around the information routes that were designed within kinship structures. We had to promote sustained behaviour change over periods of time at both individual and population levels and through targeted interventions. We also had the chance then to introduce new technologies. And for me, that was a completely disruptive time where we had opportunities to really reconfigure what diagnosis and treatment opportunities looked like, and then to be able to cascade that new knowledge through all of the guidelines and clinical practices and workforce education and those sorts of things. And so for us, it was really uncomfortable, but there were times when it was absolutely hilarious. Like, honestly, I have never laughed so much in my entire life working in this subversive kind of way of doing this work. I remember in particular, I'd just moved from Central Australia back up to Cape York, and I had my big painting, and I was going up there to a huge community meeting, and we talked at that time about how HIV was within monkeys over in Africa, and one of them old men put their hands up and said, "So it came from monkeys through to humans, did it, or to people?" Yes, it did. Yes, uncle, that's very good. Very not. Well, he wanted to know who had sex with those monkeys. And I can't tell you, my mouth kind of hung open for a moment while the whole tent just was scream laughing. And so you had to kind of really think on your feet, particularly in those public audiences, and have a bit of confidence and a bit of understanding that what you're saying will absolutely guarantee to offend someone. You just absolutely had to believe in the fact that there will also be people within that audience who needed to hear what was being said. The other thing that we found really important through knowledge exchange strategies in those early days, and I think it's continued on now, is the flow of information. So who are we trying to impact and why? A lot of our work in the early days was done peer-to-peer through a whole range of face-to-face opportunities and interactions, because we had to not only give information, but we had to take care of people's feelings, and we had to look after their hearts, because a lot of people had felt completely disenfranchised and they didn't feel that they had much self-worth. And so really building up and making sure that they felt encouraged and supported, not only in telling their stories, but also feeling empowered in something other than being a victim or an owner of a disease. You know, actually facilitating resilience and communication was something that was really important for us. A lot of other work that I was involved with in knowledge exchange strategies was me as a researcher to health professionals. And what we often found, particularly in primary healthcare settings, was that what we all experience, everyone is too busy, everyone is fairly comfortable doing what it is that they need to do. As soon as it feels like there is going to be a burden of taking on more information or having to change policy or protocol or have to collect new sorts of data, that was where we got all the hands up, and people started to back away or put some blockers up. And I could really appreciate that, because what we ended up doing, rather than talking about sexual and reproductive health, was we ended up speaking specifically about disease and burden of disease, rather than contextualising it in a whole of person's life and within the whole of cultural context. It became very strongly focused in a clinical context. And for me, that was one of the diversions that I'm hoping that we might be able to pull back from. So it became a very strong separation between clinical-based interventions rather than cultural-based practices about how to live a good life and how does sexual and reproductive health fit into that. But in terms of this, what we ended up doing was short courses. We incentivised actions and opportunities, and we facilitated things like role plays so that people felt encouraged and supported in asking the questions, particularly around contact tracing and information sharing. The other thing that we ended up doing was being a researcher and talking to community people and various degrees of knowledge, understanding. As the internet became more widely available and mobile phones were much more part of people's in people's handbags and much more available to people. The nature of the information exchange changed a little bit, but people really appreciated and responded well to infographics, paintings, local adaptation of key messages, videos. That's not BitNet, but HitNet was something else that we used up in Cape York, where we had interactive videos that were scripted out, and then people could actually choose what kinds of decision-making opportunities those young people as theatre and as scripted actors in these plays could then actually play out. And we were able to then map through what was happening and what kinds of decisions were people mostly interested about. And then we started to target health promotion and community access and really engaged people in leading solutions around those sorts of initiatives. So that was really very important. And another time I went over there to talk to people about, about sexual health, and I'm standing there and 3 people are hanging around just because they knew me and liked me. And I looked across the bloody plaza and there was a band workshop going on with over 40 people involved in that. And I went, well, something's going on here. No one wants to talk to me about STIs. Everyone wants to play in a band. So then I wandered over to the band workshop and I had like, I don't know, $50 or something in my wallet. So I put that up as a present or a prize for someone who could write the best sexual health song. And so we were able to combine these different sorts of initiatives, and we got a really cool song out of it. And someone was very happy because they got $50. Hooray! Everyone was cheering. The other thing that's really important around these sorts of strategies is the researcher to researcher. And again, the work that you do is not widely understood nor appreciated by a whole range of people in that research space. And so that what we've got to do, I think, is really commit to staying together as communities of practice and then getting involved in informing people of what it is that we are doing, just because it is so profound working in this space. So I have always got an enormous amount of support from the Lowicha Institute, from Aboriginal Health Summits, doing posters and oral presentations, demonstrating techniques. I was once asked if I could demonstrate how to put in a diaphragm. I said no. I just want you to know that. Just saying. So you do get opportunities, though, to actually really physically get involved in showing people and teaching people. Another time I was up in Papua New Guinea and we were doing some work around female condoms. For whatever reason, a lot of sex workers in PNG were able to use female condoms. And so they were using condoms, pulling them out after their clients had gone through, washing it in boiling water and then reinserting it. So I went, oh my goodness. So again, just being there on site, working with a whole lot of transport workers and sex workers meant that you could actually see what was going on and then do a whole lot of correction if possible. So that was really important in terms of the demonstration of technique. We also do things like having writers' retreats, seminars, lunchtime presentations, writing papers and writing scripts for plays or skips. And then we involved a lot of theatre groups in disseminating information. And that was a really powerful way of being able to do that, particularly in the advent of Hep C. And again, that was another kind of way of being able to just getting a whole lot of school kids and others engaged, particularly when they had a chance then to go away and do some assessments of what it was that they were able to see through those theatre groups. So it kind of differently embedded the information. Researchers to targeted populations, again, so what we wanted to do was not, we wanted to identify some key messages and develop specific resources to pilot them and evaluate the initiatives, and then share this on websites, on Twitter accounts and other kinds of information lists. And one I've found to be particularly useful is the Health Info Net. Some of the details of that are there. We also did researcher to general populations through fact sheets. We also did the conversation media training, radio programs. We sent out communiques, and then we got people involved in creating social media strategies. And then also what we found to be incredibly effective was researchers to a community of practice. We found that a lot of us were working as isolated practitioners, particularly in regional and remote areas, and there was a high level of turnover with some of the staff because the horror stories that you hear on a day-to-day basis were quite significant and very profound. And so being able to have supervised access to colleagues or other people who knew what you were trying to achieve and who could really listen to some of the post-traumatic distress that some of us ended up with, because our lives were very much reflected in the communities that we were working with. And some of the reasons why we got involved in this kind of work was actually because we're trying to resolve a lot of our own issues. And I think for us, just being aware that the fact that we do have deep trauma, that it does get triggered through doing this kind of work, and making sure that you've got access to appropriate levels of supervision and support is just critical. I have had about 3 people in my professional and personal life who were also working in this field who didn't have access to those resources successfully suicide. So in terms of this, it's really very important as part of the knowledge exchange program that we actually do learn to take care of ourselves and understand and work with people that we trust to really take into account some of the things that it's not all out there with a lot of the information, that some of it is very much in here. The other thing is that there's so much context-based experience that can't be readily captured, codified and stored. And some of those things, like I said, about working with sex workers in Papua New Guinea and being able to do that demonstration around female condoms, and then going back to the AIDS Council and saying, you know, these women aren't wet for you, actually, my brother, they're just... you know, you're training your brother there, is what I was able to say. So just using some really kind of provocative language in some ways to be able to tell these stories very clearly to those who need to hear it, and feeling powerful in doing that is something that's really important and productive. We have had an incredible history over the last 20 to 30 years within our own communities of addressing these sorts of issues in our communities. And so there is such a wealth of information to work from being able to be loud and proud, to participate in a calendar of events, to have our research leaders discuss these issues on national and international television and on international and national stages, to work with positive communities to reduce that stigma and shame and call it out where we saw it, and also then to work with people who have experienced significant marginalisation because of their behaviours, but not letting that stop that flow of information, and to do that knowledge exchange so that they can live empowered lives. The other thing that I found to be really important was that we needed to really reflect the complexity of people's lived experiences, and also then work within their networks and their relationships in order to really give true meaning to those ideas that are embodied in holism and holistic activities, particularly in this dynamic space of sexual and reproductive health. And so for us, having drawings that really did speak to that level of complexity was so critical in trying to also then help understand and codify what was going on in people's lives and how we could address people's issues around the combination of youth being HIV positive and Indigenous. And for example, in this lower graph, it was trying to really talk through what was an older man's experience of having HIV or AIDS, and where was that really mapped out against the quality of his life, and when did he need medical interventions, when was he interested in his self-image, when was he able to rethink what his purpose in life was meant to be. Those sorts of things for us, I think, are really very important. And what we want to be able to do is not ostracize or highlight anyone in a negative light, but really create among these networks and relationships of people around people who have got these sorts of experiences an empathetic response to their issues at hand. And so it wasn't just crafting knowledge exchange around fact. What we also then had to do was find ways and bring it into those networks in ways that created an empathetic response and a nurturing kindness around the kinds of capabilities that people build. And I think we've been able to do that really well. One of the things that I have found difficult to do working in this space, because of the level of anxiety that underpins a range of the sorts of initiatives that we talk about, and a lot of the fear-mongering kind of in the early days, and how we had to kind of keep awareness around the critical situation that we are in, and not kind of continue to focus on the negatives, was really to focus on how we could celebrate, where we could celebrate, who needed to celebrate. And the fact that AIDS is no longer a public health threat in Australia, I think, is something that's really incredible. And again, just promoting knowledge exchange opportunities where we focus on celebration, I think, is something that we don't do as well. What we do is highlight the deficits in our communities and the burden of disease. What we don't do is talk about those who've been able to change their circumstances, those who've been able to get empowered, those who are living good quality lives despite the burden of illness. And being able to focus some more on that through knowledge exchange strategies, I think, would be enormously empowering for a lot of us. And again, what we've got now are a whole range of different ways in which these knowledge exchange parameters are being designed and thought about. There is certainly around taking knowledge at a local level and innovation opportunities to scale. We've got different processes which highlight, the designing stage, the engaging, how you're representing it, how you actually identify what the impact is, how you reflect and sustain so that you can reiterate those sorts of ideas again. It's around taking a personal mastery approach. You can put it into a health service delivery system. You can help empower a workforce team. You could actually think about how you create shared visions for the kinds of opportunities that you want to do. And so basically there are so many different iterative ideas and processes out there about how to engage with and master knowledge exchange. But for me, it's really been about the flow. Once you understand what the flow of information is that you're trying to engage with, then you know who the partners are on that process. In terms of the knowledge exchange resources, I think that people can really make their own model and really build that in at a local level or at a regional level, or again, embedded in a community of practice. And so for us, one of the critical things that we've been able to do is kind of build calendars of events throughout the years, all with different foci, but really maintaining those slogans and key messages. We've also been really empowered through doing media training. So when I was up in Cape York, we ended up working with one of our staff members and getting media training, having cameras put in front of us, being asked those terrible questions, and then finding out the responses and getting feedback from other people within that group so that we felt really empowered and prepared. And those kinds of media training opportunities also translate very well into oral presentations and the like. The most powerful messages in terms of the narratives are those that build on your own experiences and work. Those life messages are so empowering, and people truly want to feel moved. They want to feel empowered, and they want to feel emotionally engaged with what it is that you're saying. And so to do that, we need to be artistic. We need to have flair. We do need to use different kinds of ways of communicating the same message to apply to those left and right brained approaches, and to get people interested and passionate about what it is that we're talking about. And the other thing that was really important for me was that even if we do make our own models up, in our work, we need to recognise that there are not only cultural parameters, but there are ethical, political and clinical dimensions that also need to respond to our inherent strengths as a people, our incredible resilience and our amazing capacity. So in terms of some of the knowledge exchange resources, I have really found the Lowicha Institute to be the best in Australia at having a housing and a clearinghouse response for some of these knowledge exchange resources. The Health Info Net is also deeply and genuinely committed to sharing and highlighting knowledge exchange as a process. These are fairly generalist resources. They're not specific to sexual and reproductive health. And this article also on communities of practice I found to be really useful about some of the ways in which communities of practice can be designed, the purpose, the focus, and again, you can draw on those to develop up your own. That is the conclusion slide for the knowledge exchange program that I wanted to just have a very quick flow through today. Thank you so much for your time. Hope you were able to get something out of it, or at least point it in a direction where you can take your own processes and your own ideas and develop up your own models for how you can do this in our communities. Thanks so much for your time. Take care, bye. And that's it.
Yep. Oh, yeah. Stop the recording. You want to stop sharing your screen now, Kerry? And yeah, thanks for that.
No worries.
I think there should be a stop sharing either at the bottom or from the top.
Okay, I'll just see if I can.
Beautiful. Right. Do you want to stop the recording? Oh, sorry, I'll stop the recording before the chat.
Hello, gorgeous woman.
Oh, hello there, my darling. How are you?